On to today's Health for the World International Grand Rounds. We have Dr. Wangjam, who is a hematologist and oncologist at LSU Shreveport in Louisiana, and she'll be presenting today about leukemia. My name is Anne Catherine Gertler, and I'm a second-year medical student at Wayne State School of Medicine in Michigan. I'll be moderating today. If you have any questions throughout the talk, feel free to put them in the Q&A chat at the bottom of your screen, and we'll answer them at the end. Go ahead.
Okay. Hi, thank you so much for the introduction. Good afternoon or good morning whenever you watch this recording. Today, my name is Tamna Wangjam. I'll be talking about leukemias. Though I was asked to talk about leukemias, I did split up the lecture into two, and today I'll be doing the myeloid leukemias as it was completely impossible to justify leukemia lecture that's about 2 lectures per each topic in just 1 hour. So I did split it up. So it's just going to be about CMLs and AMLs today. I have no financial disclosures, but some of the educational resources that I used that I found very helpful were the Light Against Cancer website, the NCCN websites, and these are some of the things that I'll refer to or allude to in some of the guidelines. So I thought it was worthwhile to show them up front, the European Leukemia Net or ELN, and I use a lot of the NCI-SEER database and WHO Global Can resources for epidemiological numbers. And I really like the Light Against Cancer alliance of the African Cancer Coalition with the American Cancer Society and NCCN partners that and the Clinical Health Access Initiative that came up with a lot of guidelines. It's in collaborative guidelines with NCCN to come out with the harmonized guidelines for Sub-Saharan Africa. This was where I learned a lot about what could be done and could not be done in some of the African nations, and there in NCCN is a free website where anybody who has a membership who can sign in, and you can access all the guidelines from the NCCN network. And in the harmonized guidelines from Sub-Saharan African countries, they kind of changed the color of the text to show that the grayed out areas were highly advanced for care that was not technically possible or costly for some African countries. And the ones in blue are regional alternatives to what is standard of care that may be more feasible. And the ones with a gray stripe through are not usually feasible in the region. I did not find it for anything for Asia or Central or South America. Well, in order to talk about CML and AML today, I'm going to break this lecture up into the outline as below. We'll follow this template throughout the day. Initially, I'll talk in general about leukemias and then the clinical presentation and the differences between CML and AML, sorry, and then go on to talk about CML more in detail and AML separately with a little bit of time dedicated to APL, which is AML M3, because it's very important. Please note that because of the wide, broad nature of the learners who would be accessing this lecture, I've tried to be as broad as possible, but I did include a lot of advanced slides that I used to teach my HEMONC fellows and some practitioners. And I'm going to go through those slides fairly quickly, just focusing on the main points, but stopping long enough that people can pause in the future and watch those data later on. Okay, so leukemia is a clonal disorder of hematopoiesis, usually of the early blood-forming cells, and characterized by abnormal accumulation of white cells here. And in simple terms, they can be classified into 4 broad terms, and we'll see in later slides that it's not quite simple like that. But based on the cell lineage, you can classify them into myeloid and lymphoid origin, and based on the maturity, which determines cell maturity, which determines the disease tempo and acuity of presentation and need for treatment, into acute and chronic. Today, we're going to talk about acute myeloid leukemia and chronic myelogenous leukemia. Epidemiology from the WHO's GlobalCan data shows how leukemia is far more, and the new cases are far more higher in mostly the developed countries in North America and parts of Europe and Asia and Australia. But if you look at the mortality, it is a lot higher. It's flipped. It's a lot higher in the less developed countries where resources may be more scarce. In Mexico, Central and South America, and in parts of Africa and the Middle East, Asia, and some parts of the Mediterranean and Europe. And I did put in this slide because we have a lot of learners from Africa, and I wanted to show where the prevalence was, the incidence was the highest. Most highest countries in Morocco, Tunisia, Libya, Egypt, in Eritrea, Ethiopia, Kenya, and Somalia. And this is pretty much the same in terms of mortality as well, though some data from some countries were lacking, so it may not be the true picture. In the US, from the NCI SEER database, CML is not that common. It just makes up about 0.5% of all cancers, of all new cancers, and about just 0.2% of all deaths from cancer. This is a 2021 data. And as you can see from the 1990s to now 2019, the incidence has remained pretty much the same, but the mortality continues to drop. And this was around the time when the TKIs or Imatinib was out in the market. The trials were going on here, and it came out and was approved in 2001. That really changed the landscape of CML care. And now, in the past decade, the 5-year survival is pretty good, 70.6% and improving. And the median age of a diagnosis and presentation it's older individuals usually about 65 years in the developed world. Though in Africa, I found some data that showed that the patients present younger. The median age is younger, about 44, 35 to 44. And the only known potential risk factor is in about like less than 5% of the cases exposure to radiation in the past. As for AML, it's also quite uncommon, just makes up about 1.1% of new cases of cancer in the United States, makes up a little bit more, about 2% of all cancer deaths. And a lot worse prognosis with 5-year relative survival rates in the past decade of about 30%, though it continues to improve. And currently, for some good risk patients who are younger and able to tolerate intensive treatment a lot better, 60% or above. And the risk factors associated with AML include chemical and environmental exposures, commonly radiation, industrial solvents, chemotherapy, very common, and inherited cancer predisposition syndromes like bone marrow failure syndromes, Down syndrome can be associated with increased lifetime risk for AML. Okay, this cartoon here shows a simplified version of normal hematopoiesis, very important in understanding the pathogenesis of any kind of leukemia. In general, what happens is that there are multiple insults to the progenitor cells, which accumulate them, either they are germline or some are acquired. In CML, it's really acquired. This causes malignant transformation, which would increase in proliferation and decrease in apoptosis and developmental arrest of these progenitor cells. And this will cause accumulation of these immature cells, or blasts as we call them, in the either in the marrow, or sometimes they spill into the blood or the tissue. That's what we find at the time of diagnosis. And this will cause decrease in the normal hematopoiesis, and that will lead to the signs and symptoms that we see from the leukemias. So in AML, it's more acute. The neutropenia, the cytopenias are more severe. The tempo of the disease is a lot faster. Patients usually present with very high white count. Sometimes in rare cases, low white count with increased blast in just the marrow, but not in the periphery yet. Cytopenias, which like for example, with the white cells being low, patients can present with fevers, infections, recurrent infections, with anemia, symptoms of anemia, bleeding, wrist, and easy bruising because of thrombocytopenia. Constitutional symptoms like fever, weight loss, drenching night sweats are common in some, and some patients can present with positive lymphadenopathy or hepatosplenomegaly. Not so common in the myeloid leukemias, more so with ALL, although it can happen. Or it can happen, AML can present as a solid mass, still treated as a systemic disease though. And to note, in AML or any acute leukemia, there are certain emergent complications that may need immediate attention and treatment, like hyperleukocytosis, meaning very high white cell count, about usually defined as about more than 50,000 with or without signs of leukostasis. Disseminated intravascular coagulation, tumor lysis syndrome, neutropenic fever. Even though these are very, very important topics, I'm not going to go into the details of it today because of the lack of time. In CML, it's a lot more indolent course. Usually about 50% of the patients are asymptomatic, and in others who do present with symptoms, mostly present with vague constitutional symptoms like fatigue or night sweats or weight loss or appetite and sometimes fever. Splenomegaly is quite common with or without hepatomegaly that can cause abdominal discomfort and early satiety. And it's very rare to see hyperleukocytosis in CML. I mean, it's usually about 50, but even if there is hyperleukocytosis, no signs of leukostasis usually because of the maturity of the cells in the cells involved. And a diagnosis, about 85% of these cases present in the chronic phase, and most are Philadelphia chromosome positive at the time of diagnosis. I just wanted to put this slide out there, though the French-American British classification is somewhat outdated now. There are some pathologists and some clinicians which may still use it, so I wanted to put it out there. This is based off of the morphology and not so much indicative of the molecular biology that is most closely associated with disease prognosis and treatment, predictive of treatment. Right now, the most recent WHO classification in 2016, this I put it out there so that you can see what are the other things. Today, we'll just talk about one of the myeloproliferative neoplasms, CML, as well as the acute myeloid leukemia. As you can see here, as contrast to the FAB classification, the AML classification in WHO is based off of genetic abnormalities, the molecular and cytogenetic abnormalities, and other maturation changes that are predictive of prognosis and predictive of treatments. As for diagnosis, in CML, you usually see an older individual, usually a male, presents with a very high white count, fairly asymptomatic. They may have a big spleen on physical exam. What do? We first start off with a CBC with a differential and a peripheral smear, and this is what you'd see in the peripheral smear. It's as if the bone marrow is filled into the peripheral blood. You'll see the neutrophils left shift with all sorts of early immature neutrophil granulocytes in the peripheral blood, which are usually not seen in the blood. This is more mature. You can see how there are some promyelocytes, some myeloblasts, some can't see myelocyte, but usually the myeloblasts are usually less than 2%. The more the blast, the phase changes, and we'll talk about the phases in just a little bit. There would be, it's usually associated with basophilia as well, absolute basophilia. Here's a basophil here. A bigger picture here looks like this. We also need to look at the bone marrow analysis for cytogenetic workup, which is very important, not just for diagnosis, but also for disease monitoring. And in the karyotyping, you see the translocation 922 or the Philadelphia chromosome. This is the band patterns that you see in karyotyping. And on the fish, and on the it can be done on the peripheral blood. You see the BCR-ABL fusion over here. It lights up. It's usually red and green, but here it is what you see, a yellow with a mix of red and green here. That's a BCR and ABL fusion. And in molecular studies, you can do, very important is the PCR, and this is done, can be done on peripheral blood, and you see the bands here. And we also need to get baseline CMPs, of course, to look at the organ functions, viral serologies, and ECG is very important because of a lot of TKIs we use now these days have issues with QT prolongation. We won't go through this in detail, but the main thing about CML that's diagnostic in the hallmark is the Philadelphia chromosome and the translocation 922, wherein the ABL oncogene from chromosome 9, there is a translocation between that and the breakpoint cluster region gene on chromosome 22, causing the BCR-ABL tyrosine kinase gene that is constitutively active and produces the BCR-ABL fusion protein. This tyrosine kinase activity is what is inhibited by the Imatinib or any of the other TKIs. This constitutively active BCR-ABL tyrosine kinase causes increase in proliferation, decrease apoptosis, and okay, so this is important. CML is a triphasic disease. Most patients at the time of presentation, about 80 to 90% would present in the chronic phase. And if untreated, it can remain stable for several years, about 3 to 4 years. But with treatment, patients with current treatments, patients can survive more than a decade. And in fact, with current treatments, patients can survive as good as their normal general population. In accelerated phase, the blast count, I'm taking the WHO because, as you can see in upcoming slides, there is a difference in diagnosis criteria between WHO and MD Anderson criteria and some other criteria. But we'll go by the WHO here. Accelerated phase, there are about 10 to 19% blasts, more than or equal to 20. There would be in the blast phase or blast crisis CML. It's important to know this at the time of diagnosis because number one, it's a different prognosis. Chronic phase, great. They survive very well. This is the different years, all chronic phase, different years. This top one is 2001 to present. This is after Imatinib. This is before Imatinib. And same thing here for accelerated phase. It's a little bit worse, but with treatment, they can do very well as well. And with blast phase, it's a lot worse, about 6 months median survival, if not consolidated with more aggressive treatment like an allogeneic stem cell transplant. And blast crisis can be either lymphoid or myeloid. The myeloid is more common and it happens in about 60%. And the lymphoid blast crisis happens in about 30% of the cases of CML that present with blast crisis and tends to do a little bit better. As this is the diagnostic criteria for accelerated phase. As you can see here, WHO has a different set of numbers than MD Anderson or the European Leukemia Net. But what is important is 20% or 30%. Either beyond 20% is a blast crisis. Beyond 30% is a blast crisis for ELN and MD Anderson. That's important. And in all of these criteria, basophil more than 20% makes for accelerated phase. And blast phase, 20% and 30% based off of the criteria you choose. WHO is more universal, and the Anderson criteria is usually used for clinical trials. But either way, accelerated or blast phase, advanced phase CML is treated more or less similar, but there are minor differences that we will talk about in the upcoming slides. A little blurb on the prognostic scoring systems. There are many systems out there, but we don't need to get into detail. The most commonly and the oldest and most validated would be the so-called criteria, wherein you use four determinants from the patient's age, spleen, size, below the centimeters below the costal margin, the platelet count at the time of diagnosis, and the blast cell count to come up with a risk criteria into low risk, intermediate risk, and high risk. And it's important to know because this risk scoring, whatever system you use, would help you determine the kind of treatments you can pick up front or for consolidation. Okay, coming to the treatment. For chronic phase CML, it's the mainstay. It's really just tyrosine kinase inhibitors and Imatinib. The first generation TKI is still very much effective, though the second generation TKIs, the Satinib, Nilotinib, and Bosutinib, has kind of been more popular in the United States. And the reason is usually because of a faster and deeper response. And we will see that in the upcoming slides. But at the end of the day, the overall survival differences has not been really met yet. So even though in the US, the trend is to usually go for the second generation TKIs, at least in the advanced phase, but even in the chronic phase, a lot of centers and practitioners tend to do that because of faster and deeper response that can be achieved with the second generation TKIs. But Imatinib is still a very good choice. And the goal is to try to achieve the response milestones, get a deeper response as soon as possible, because that's predictive of a longer survival, to minimize the toxicities from these treatments, because even though they are all pills, there are a lot of toxicities that we need to be mindful of, and to maintain the patient's quality of life, and most importantly, to prevent progression to advanced phase CML, because the prognosis is widely different. And when we think about what to do for a patient, when a new patient comes in, deciding on the treatment, we have to look at the disease risk. The higher risk for intermediate or high risk, most practitioners would choose a second generation TKI. And then we also have to pay attention to the patient's comorbidities and their goals, whether they, what their life goals are, and whether they'll take a pill that they take twice a day or once a day, whether they want to shoot for treatment-free remission long-term, wherein there is a trial for discontinuation of the TKI after they meet certain very strict criteria. That's a possibility. So depending on that, you may want to go first generation versus second generation TKI. And of course, the toxicity profile of each TKI and match it with the comorbidities of the patient and try to minimize the toxicity. And other treatments upfront could be interferon. That's kind of fallen out of favor post Imatinib era, and stem cell transplant. These are for more advanced phase and second or more lines of treatments. We'll talk about them in the upcoming slides. Okay, this table is, I put in a summary of all the TKIs here, and we won't need to go into a lot of details about each and every one of them. But important to note that Imatinib, the first TKI that was approved in 2001, still remains quite effective, and it is approved for chronic accelerated and lost crisis phase upfront. And not usually second line. Not usually used second line, though it can be. And its main side effects include fluid retention or edema, hepatotoxicity that can be quite severe in some cases, and sometimes heart failure. Others like myelosuppression, fatigue, and cramps are very common, but not too severe. Please note that myelosuppression and fatigue usually are very, very common side effects with any of these oral TKIs. Dasatinib, the second generation TKI that was approved in 2006, is a lot more potent TKI, about 200 to 300 times more potent than Gleevec. You see this parentheses, it shows the relative potency of each TKI as compared to Imatinib. And given orally, once a day or without food. Note that some of these TKIs need to be given with food or without food as well. That will change the bioavailability and thereby the absorption and the dosing of the drug and efficacy of the drug. The Dasatinib, the most concerning side effects are pleural and pericardial effusion, pulmonary hypertension, and bleeding because of platelet dysfunction, because of an aspirin-like effect on platelet function. Prolonged QTC interval is also a problem, but not as bad as with nilotinib. And nilotinib is given orally. This is the only one that's usually given twice a day. So something to keep in mind if you have a patient who has issues with compliance. Its main side effects or adverse event is atherosclerotic disorders with coronary, cerebral, or peripheral vascular disease. QTC prolongation, it has a black box warning for that. And pancreatitis, those are the most concerning side effects. Electrolyte imbalance are also very common. If you put that together with a prolonged QTC, that really is not very good for arrhythmias. So something to keep in mind and monitor. And bosutinib, the second generation TKI, is given once a day with food, and its main issues are really liver issues or pancreas issues. And like with other TKIs, it also has myelosuppression and fluid retention as problems. Ponatinib is the third generation TKI that is used for chronic phase or other advanced phase CML after resistance or intolerant to prior TKIs. And it is the only TKI that is effective for the T315I mutation. None of these other TKIs are effective in that particular mutation of BCR-ABL. And its main adverse event is arterial thrombosis and liver toxicity. And it has a black box warning for both. And it can also have severe issues with fluid retention and edema. Okay, I have put in the next 10 slides or so the main trials that have led to the approval of all these TKI, but we won't go into very much detail. I do want to keep this slide for your review later on. The IRIS trial is probably the most important TKI trial, the first one that got Imatinib approved in 2001. A very big trial with more than 1,000 patients that were randomized to Imatinib versus the standard of care at that time that was interferon alpha with cytarabine. And in this study, well, look at this slide. There is not much difference here between the Imatinib and the standard of care arm because there was a lot of crossover. About 65% of the interferon alpha and cytarabine patients cross over to Imatinib in a very short period of time, really about within the first year or so. So this graphs don't look so different, but the Imatinib arm, just looking at the 10-year follow-up on the Imatinib arm, the complete cytogenetic response rate was 92% at 10 years, and major molecular response was 93% at 10 years, and molecular response with a log reduction of 4.5 was 63%. These are all markers that are predictive of survival, and that's important. And the 10-year freedom from transformation to either accelerated or blast phase is 92%, with an event-free survival of 80% with just the Imatinib. And the Sichuan trial was the trial that brought us the Dasatinib, that compared the Dasatinib to Imatinib. What I want you to see here is that even though the MMR, major molecular response, at 12 months and 5 years is better with the Dasatinib, and comparable MR 4.5, the main point is that the transformation to advanced phase CML was pretty similar between the two, and the 5-year overall survival was pretty similar. So even though it seems like the dasatinib was faster and at getting response and getting deeper responses, the survival remains pretty similar. And that's the same for the other second generation TKIs. Nilotinib was studied head-to-head with and compared with Imatinib on the INES-ND trial. And here, if you look at these numbers, Nilotinib does better in terms of the MMR rates at 1 year, 5 years, 10 years, and the MR 4.5 at 1 year, 5 years, and 10 years. But the 3-year overall survival and the 10-year overall survival between the two different dosing regimen of nilotinib as well as the regular standard imatinib seems to be fairly comparable. And then the trial that looked at bosutinib compared to imatinib, the before trial, same story. Even though the MMR rates were a little bit better with the second generation TKI, they were faster to achieve the milestones. But at the end of the day, transformation to advanced phase CML and 5-year overall survival is similar. So what does it mean? Even though, and this may be quite relevant for our colleagues in Asia or Africa, where imatinib is the main drug, especially for Africa, as I was looking through the NCC and harmonized guidelines. If we can get patients on imatinib, if we can catch patients earlier on chronic phase, get them on imatinib, get them taking it properly, compliant, monitor them closely, then we can get as good results without getting to the second generation TKIs if that's not available. So doing it right and doing it very fast in a timely manner upfront is the key to areas where resources may be limited and access to second generation TKI or third generation TKI or other cytoreductive treatments or allogeneic stem cell transplant for CML are not available. Okay, response monitoring is very important in CML. And here we're looking at the number of leukemic cells. And here this slide shows the BCR-ABL to the regular ABL gene ratio. And this, as we go down this area here, it is the deeper response down here. So up top, first will be hematologic response, where you're looking at the blood counts and the WBCs improve. It's less than 10,000. Platelets are better, but more than 100 and less than 450. And there are no basophils, no blasts, no extramedullary involvement. But then when you're looking at the karyotyping, you are looking at the number of leukemic cells. Then you discuss the cytogenetic response here, and we'll talk about the cutoffs, about the percentages, and complete cytogenetic response about like 1 to 35. And then deeper than that would be the molecular response, where we're looking at the PCR and looking at the BCR-ABL ratios here. Less than 0.1% or IS ratio would be the major molecular response. The goal is to try to get a deeper response at a certain interval, and we're going to talk about the milestones that need to be achieved in a timely manner and what are the guidelines on that. The deeper and faster, the better. Okay, these are the response criteria. We talk about the cytogenetic response that's determined by the karyotyping on a 20 metaphase chromosome, and they need to be done on a bone marrow. So quite problematic for some areas where bone marrow biopsies and cytogenetic analysis may not be readily available. Again, it can be spaced out from the regular more frequent testing. And for complete cytogenetic response, you need 0% of those abnormal karyotype with the PH chromosome. And partial is 1 to 35. Molecular response, we're looking at the PCR and the percentage of BCR-ABL fusion to the regular ABL. And major molecular response is defined as less than 0.1%. And MR4 is less than 0.01%. That is there's a 4 log reduction in the BCR-ABL compared to the regular ABL. And these are the guidelines for monitoring from both ELN, European Leukemia Net, and NCCN. And usually a diagnosis, we talk about this, is similar. And during treatment, the PCR is the key that needs to be monitored, usually about every 3 months, but in areas where it may not be readily available, it can be done up to every 6 months. And at 6 months and at 1 year. And these are the milestones that are recommended or be achieved in a timely manner. If the milestones are not achieved by the recommended time, that there is possible resistance, you need to evaluate the patient for it and then switch treatment or increase dose, whatever may be applicable. And these are pretty much similar. This side is the NCCN guideline. This is the ELN guidelines. But at and we are looking at the PCR with the BCR-ABL ratios, when it's at 3 months, you expect it to be about 10%. But if it continues to be above 10% at 6 months, it's concerning, it's red. So it is most likely TKI resistance. But before we do anything, we have to always look for look for patient compliance, drug interactions, because that's quite common with TKI, why the efficacy is reduced, and then look for mutations that may be the cause of TKI resistance. And this and at 6 months, if the ratios are still more than 10%, there's a concern. We reassess the 3 main causes that we talk about for possible resistance and see if correct any of them. And at 12 months, it should be at least about 1% or less. And if we don't achieve any of these milestones in a timely manner, we keep reassessing and see if there's a need for change of therapy. Okay, going to the treatment of relapse refractory disease or second-line TKI, it's really the same TKI, usually second-generation TKI or the third-generation TKI ponatinib. We already talked about all those in the initial table, and we talk about the causes for TKI resistance. And the choice of the second generation TKI is really dependent on the mutations and the comorbidities and adherence to treatment of the patient. And other second line treatments that are available could be interferon. It's important to know because it's the only choice that can be safely given in pregnancy. Other myelosuppressive agents like hydroxyurea, busulfan can be given. Omacitexin is a protein translation inhibitor that can be given for CML in chronic or accelerated phase that's resistant or intolerant to more than or equal to two TKIs. Allogeneic stem cell transplant is the only proven cure for CML, and it's really for either a patient who presents with blast phase and then achieve a chronic phase after initiation of the TKI, or for patients who are really intolerant or progress through several lines of TKI, at least more than or equal to 2, because of the increased morbidity and mortality associated with it, even though this is the only chances of a cure. And it has to be with a very good donor match. And today I will be talking about stem cell transplant for CML because of time. And Asciminib is a first-in-class TAMP inhibitor. It's in the process of approval, but not yet approved by the FDA yet, but upcoming treatment possibility in the future. And for advanced phase CML, accelerated phase, you can start with, if there are two kinds, one that presents that progresses from a chronic phase CML while on TKI treatment, then you change the TKI and then take the patient to stem cell transplant. And for de novo accelerated phase CML, you can still use a TKI, and depending on whether what the patient's risks are, how their milestones are achieved on the treatment, you can consider a stem cell transplant. And in general, second generation TKIs are recommended for patients with any advanced phase CML or accelerated phase and blast crisis. And in areas and resource restricted areas where the second generation TKIs may not be available, the options would be to increase the dose of the first generation TKI Imatinib from 300 to 600, or to add something like hydroxyurea that may be easily available. And for blast crisis, the goal is to try to get the patient to a chronic phase, and then with either TKI or chemotherapy that is tailored to either lymphoid blast crisis or a myeloid blast crisis, and then just consolidate them with an allogeneic stem cell transplant. Okay, take-home points. Before we go to take-home points, just a quick blurb on the requirements for TKI discontinuation. There's a lot of data out there. I took all of it out, but just condensed it down to the ELN and NCCN criteria for 2020. If a patient meets all the strict criteria, an adult in chronic phase, if they cannot present with an advanced phase CML, who have been on an approved TKI for the past 3 years with no prior evidence of with evidence of stable molecular response, at least MR4, for the past 2 years, as documented by more than or equal to 4 tests, each performed about 3 months apart, and they have access to reliable quantitative PCR testing, and they can have monthly molecular monitoring. They are compliant patients, and there is the possibility of prompt resumption of TKI within 4 weeks of loss of MMR while monitoring. Those are the patients who can be considered for safe discontinuation of TKI. Something that's very important but may not be very possible in Africa or Asia. Okay. Any Just to take a quick break here, any questions from the group? I say something.
If you do have any questions, feel free to put them in the Q&A section in the chat.
Okay. All right, so I do not see anything there. So moving on, we're gonna go real fast. We have about 15 minutes on this. So moving on to AML. AML, the diagnosis is made by the presence of about more than or equal to 20% myeloid blasts in the peripheral blood or the bone marrow. And the myeloid blasts in general, they are immature cells. This is the peripheral smear of a patient with acute myeloid leukemia without any maturation. They are bigger. They have a very high NC ratio. They have this more open chromatin with nucleoli. It's not very prominent in this picture here. And in myeloid leukemia, there can be cytoplasmic bodies called auroids. It's more common in certain kind of AMLs like the AML N3 or acute promyelocytic leukemia. Except for patients who have certain core mutations, like the core binding mutations in version 16 or translocation 1616, translocation 821, and APL that has the classic translocation 1517. And we already talked about the clinical presentation. When a patient presents with the classic present, they usually could, even though it's older individuals, it could be a younger patient too, who presents with maybe like a very high white count. They have bruising everywhere. They have low platelets. They have anemia. They're tired. And then you look at the peripheral. You look at the peripheral smear. This is what you see. We need to do the bone marrow aspiration and biopsy. Important for immunohistochemistry and immunophenotyping. And important to look at the cytogenetics and molecular genetics for prognostication that will help with treatment choices and consolidation in the future. And other tests to be done are baseline complete metabolic panel, an EKG and echocardiogram to look at the EF, because there's a lot of use for anthracyclines that can cause cardiomyopathy in AML treatment. And important to look for tumor lysis with the CMP, uric acid, and DIC with the coagulation panel, fibrinogen, LDH, and D-dimer. And in the immunohistochemistry, we're specifically looking for MPO in the cytoplasm, CD34, CD117, HLA-DR, CD13 and 33. And prognosis in AML depends on the age of the patient, functional status of the patient, medical comorbidities of the patient, and cytogenetic risk. That's most important. And the most validated risk stratification by cytogenetics is the European Leukemia Net risk stratification, wherein patients are classified into favorable risk, intermediate risk, and adverse risk. And we don't need to remember everything, but remember that all the core binding factor leukemias, as well as the patients with APL, are favorable risk, and patients with a mutated NPM1 without a FLT3 ITD or a FLT3 ITD with a low allelic ratio less than 0.5 are considered good risk. And patients with biallelic mutated SEPA are also considered good risk. That's important to know because that will help us determine how we treat these patients. And it's important for prognosis. The good risk patients do so much better than the intermediate risk or the higher risk patients. And the induction for AML, the treatment choice is based off of the patient's medical fitness and comorbidities, whether patients are medically fit to get intensive curative intent induction versus they are because of their comorbidities or advanced age, they are not or patient choice, they are not able to get intensive treatment. So the goal will be more palliative. And this slide pretty much summarizes a lot of the slides that I'm going to go through in the next 10 or 12 slides. For the backbone would be a 7+3 regimen with cytarabine or RSC, a standard dose of 100 milligrams per meter square, continuous running IV for 7 days, given along with an anthracycline. Usually daunorubicin 60 or to 90 milligrams per meter square for the next 3 days IV, or idarubicin 12 milligrams. They're pretty much comparable, but looking at the Sub-Saharan harmonized guidelines from NCCN, it seems that idarubicin may be more difficult to, or less readily available in a lot of African institutions, and daunorubicin may be the only choice. And for patients who have treatment-related AML, who have AML with MDS changes, or have adverse risk or poor cytogenetic risk, the options that are better than regular 7+3 is the liposomal 7+3 that has a 5:1 molar concentration of daunorubicin and cytarabine, also called CPX351 or Vyxeos. And it's given at days 1, 3, and 5. It can be done outpatient because it's a lot less aggressive upfront, and patients usually need admission in the next coming weeks or so for management of severe cytopenias or neutropenic infection, fever and infections like that. And other options for this higher risk group of patients would be hypomethylating agents like azacitidine with Venclexa, that's a BCL2 inhibitor. The addition of a third agent to the classic 7+3 backbone has been something that's upcoming, and 2 approved treatments in the United States are the FLT3 inhibitor for both FLT3-ITD and TKD patients, midostaurin, that's a pill, and for patients with AML who are CD33 positive, which by the way is positive in about 80%, who are favorable or intermediate risk patients can get gemtuzumab ozogamicin. That's an antibody, CD33 antibody and drug conjugate with caliciamycin. And this study looks at the different dosing of daunorubicin because there's been always a lot of debate about what dose is the optimal dose, and it shows that the lower dose of 45 mg per meter square is inferior to 90, and there being no difference in serious adverse events. So hence the standard dose of 90, but in some centers 60 is also a dose that can be used for slightly older individuals. And this study, the Ratified Trial, was the trial that introduced the midostaurin added to the 7+3 backbone, and it was compared with placebo added to the 7+3, and it improved the overall median overall survival compared to the placebo and 7+3, and so this is approved for FLT3 positive medically fit AML, and midostaurin once added upfront can also be used for in consolidation cycles as well as in maintenance. And this was a study that got the liposomal 7+3 approved, but because of the time constraints, I'm gonna go through these study slides really fast. It really improved the overall survival. Bear in mind that the study population was older individuals, 60 to 75%, and Vyxeos really improved overall survival from 6 months to about 10 months. Okay, so in summary, for the initial treatment of medically fit AML patients, after diagnosis, you try to induce them and then reassess them with bone marrow biopsy, induce them medically fit with 7+3. Then you restage them with bone marrow biopsy. Usually, ideally, we do a day 14 marrow wherein you are expecting to see marrow hypoplasia. meaning that the cellularity of the marrow will be less than 20%. And then at count recovery, usually anywhere from day 21 to day 28 from induction, you look at the count recovery marrow and look at the morphologic response. If there's complete response, then depending on the risk, if it's a higher risk, then you intermediate or high risk, then you consolidate with allogenic stem cell transplant. And if it's a low risk, and some intermediate risk patients after discussion can go for chemo consolidation, usually with high dose Ara-C, usually 3 or 4 cycles. And for patients who are not medically fit to get intensive therapy, several options do exist nowadays in the past several years. In the past, it used to be just hypomethylating agents like azacitidine and decitabine given IV, usually outpatient, or low-dose cytarabine. But nowadays, with the advent of venetoclax, that's a BCL2 inhibitor, there has been much improvement in the outcomes of patients who are not able to get intensive therapy. Just as a gross comparison with the HMAs and the low-dose Ara-C, the median overall survival were about 5-6 months. But with the addition of Venclexa or venetoclax BCL2 inhibitors, it's improved to more than a year. And it's still about a year and a half, still counting. So very, very promising. Though this may not be yet available in Asia or Africa and South and Central America, but important to know upcoming. And then there are other targeted drugs for certain mutations, IDH1 and IDH2, ivosidenib and inacidinib respectively are pills as well that improve the survival for patients unable to get intensive therapy to about 9 to 10 months, just to even taken together. And glazagib is non-targeted therapy. It's a targeted therapy, but not targeted to a specific mutation. It's a hedgehog inhibitor that can be used with low-dose cytarabine, also comparable survivals with IDH1 and 2 inhibitors, about 10 months or so. And if none of the options are good for the patient or working, best supportive care with or without hydria and transfusion support is an option. And this table here summarizes the most recent FDA approvals in the United States for newly diagnosed AML in the past year. And very nice to look at from Dr. DiNardo and Dr. Wei's paper, summary paper in Blood. So I left it there. Time is short, so I'm gonna keep skipping. And this is the venetoclax data combined with azacitidine. You can look at the historical azacitidine data, 20% CR rates, and median survivals of about 10, and with the venetoclax, 70% CR and CRI rates with 17 months a median overall survival. And for relapse refractory AML, in addition to all the targeted therapies we talked about before, one additional targeted therapy is a FLT3 inhibitor, gilteritinib. Oh, sorry, there is a slight spelling error there. I'll change it out later. And non-intensive treatments, the same as before. And intensive treatments include a lot of different combinations with anthracyclines, and includes, it could be just without an anthracycline, high dose Ara-C without anthracycline, or flag would be fludarabine with Ara-C and idarubicin and GCSF. FLAG-IDA and MEG are very popular second salvage treatments for relapse intensive salvage treatments for relapse refractory AML. And others like clofarabine based regimen, cladribine based regimens are out there, but they're all kind of similar. It's more about institutional and provider preference. All intensive regimens that need inpatient care. And this slides from Dr. DiNardo and Dr. Wei's summary paper, again, just the recent FDA approvals in the United States for relapse refractory AML. These are the IDH1 and 2 inhibitor data for relapse refractory AML. And for consolidation, we already talked about in the summary slide that favorable risk, we go with chemo consolidation, and for unfavorable risk, take the patients to allogeneic stem cell transplant as soon as possible. This is the summary of what we talked about just now. And special scenarios, pregnant patients. We are afraid to treat pregnant patients, but AML, we need to treat them as soon as possible. It's okay to give induction in second and third trimester if you may have to wait out the first trimester because of concerns of risk to the fetus. And you have to dose the chemo by the actual body weight and try to deliver the baby as soon as possible at maturity, more than 32 weeks. And if AML patient presents with a single extramedullary site, or called a chloroma or a sarcoma, you treat it just like AML, like with systemic treatment. And for AML supportive care, important blood products need to be leukocyte reduced and irradiated because they are severely immunosuppressed. Tumor lysis and DIC monitoring and prophylaxis or management is very important. Growth factors as needed can be given. Preventative antimicrobials are institutional guidelines are very important, especially for prolonged neutropenia. HLA typing and MRD testing, we won't talk about it today, but something to keep in mind for in areas where allogeneic stem cell transplant will be an option. And then quick blurb about APL, very important subset of AML, or it used to be AML-M3 or acute promyelocytic leukemia. Very important because it is it usually presents as a medical emergency with a distinct coagulopathic syndrome. They usually present with DIC, and that they have a early mortality of about 90% in the first week because of bleeding from DIC. But it's very curable, and about 80% can be cured without chemo, without chemo, 80 to 90%. And the hallmark is the translocation 1517 and the PCR, which show the PML RARA fusion. And the ATRA, from starting with ATRA, if you suspect that a patient has APL, go ahead and get started at ATRA. It's usually widely available orally, and it has to be available in community hospitals so that it can be started in a timely manner to prevent the devastating consequences of DIC and bleeding and death from it. And treatment really is based off of the risk, and the risk stratification into high and low risk is based off of the white count. If white count's more than 10, it's considered high risk. For high risk APL, you use ATRA and anthracycline, like daunorubicin and idarubicin. In areas where it's not available, we can use hydroxyurea. And we can use gemtuzumab oxaliomycin with the ATRA as well. For low risk APL, just ATRA and ATO based induction and consolidation is good enough with very good cure rates. Okay, that concludes my lecture. I think I was able to make it in time. Any questions?
Again, if anyone has any questions, you can put them in the Q&A.
Okay, well, of course, my email's out there. And if anybody has any questions or concerns or any feedback on how we can do this lecture for the lymphoid leukemias, please email me. And Anne-Marie, before we sign off, please let me know how I can create a new date for the lymphoid malignancy.
Oh yes, perfect. I will email you after this and we can figure it out. Well, thank you so much for giving this lecture. A reminder to everyone, these lectures are always recorded and uploaded to the Health for the World website. Well, thank you so much, everyone. Have a great day.
Have a good day. Bye-bye.